Good evening. Welcome to this fall's first Fall Voice webinar. Tonight's presentation is on high-resolution pharyngeal manometry. We'd like to start by thanking our sponsor, Medtronic, who gave us a nice donation to make this possible this evening. Our panelists tonight are Dr. Ashley O'Rourke and Kate Davidson from the Evelyn Trammell Voice and Swallowing Center at the Medical University of South Carolina, and myself, Greg Post, Medical College of Georgia, and our fellow here, Stephanie Teng, also at the Medical College of Georgia. I'd like to take a second here to give a shout out to the Fall Voice Conference. It's going to be in Seattle, Washington this year at the Motif Hotel, and early registration ends in just a couple of days. So we encourage you, if you haven't already registered, to go ahead and register for this outstanding multidisciplinary conference out in Seattle. In addition, as you see on your screens, feel free to send questions. Dr. Teng will be reviewing them as they come in, and if any are deemed worthy, we'll discuss them with our panelists. So let's talk what we're going to review tonight. We're going to talk the background of high-resolution manometry, a little on the esophagus, but concentrate on pharyngeal manometry, and then discuss how to incorporate high-resolution pharyngeal manometry into your clinical practice, both as a diagnostic and a therapeutic tool. The aims of manometry in general, it was initially devised to better understand the physiology of the pharynx and esophagus, to explain cervical and esophageal symptoms, and to make more sense out of abnormal bolus transit. By using manometry, it was hoped that we could understand the pathophysiology of what was going on so we could have better targeted treatment. If we could specifically determine the problem in the esophagus and pharynx, perhaps a targeted diagnosis could lead to more targeted treatments and hopefully improve patient outcomes. In the history, it started with a rather ungainly water perfusion system, and then a few years later into solid state systems. This was a marked advance, but only 3 or 4 sensors that were upwards of 5 centimeters apart. So a lot of missed data, a lot of guesswork going on. So the pull-through technique was devised. So you literally would place the catheters at the lower esophageal sphincter, do a series of swallows, pull it further north, or more fully cephalad, do more swallows, and continue through the pharynx. Now, technology with high-resolution manometry, we now have 36 sensors, which, depending on the type of catheter, can be 3/4 of or 0.7 centimeters to 1 centimeter apart from one another. There are 2 standard catheters, 4.2 or 2.7 diameter catheter, and this allows us to go from the data acquisition of high-resolution manometry to the 3-dimensional esophageal pressure topography, which we'll be using and highlighting this evening. These were the standard sensors used and still used for many years, just a small number that we'd have to pull through at different areas, and this is the standard position of them up in the pharynx. This is a standard HRM catheter. Each of the 36 sensors has 12 different pressure-sensitive areas on it, so you acquire a tremendous degree of data using these catheters. This is an old school manometry thing here. This is pharyngeal manometry, and you notice this is in more or less the pharyngoesophageal segment. With swallowing, you get a trough as pressure lowers and almost a peristaltic contraction of the tongue base and pharynx above it. So a normal study, but not a ton of data there. And even an older school version here, you see the M pattern here, but a dead pharynx in this individual. Not a lot of data. Then Klaus began to work with this and devised the high-resolution manometry being used to make spatiotemporal plots in which both pressure, time, and location were then used so that you could actually interpolate the pressures across all of the different channels. So up here, the upper esophageal sphincter going down to the lower esophageal sphincter here. So you had not just 36 input data points, but the system would interpolate the pressures across all of the channels, providing a tremendous amount of data and very useful information. This would then be color-coded according to the pressures. The cooler or wintry colors are the lighter pressures, and the warmer, redder colors are higher pressures. And this would then applied, so you went from conventional solid-state manometry plots to the HRM system that would acquire the data, and then three-dimensionally have the spatiotemporal plots that we now use today. A normal swallow from the upper esophageal sphincter high pressure zone, the pharynx, down to the LES. On the left side, you have the pressures. On the bottom, the individual swallows as one proceeds through the examination. And if you look closely at this, once again, upper esophageal sphincter, relaxing during a swallow, and the lower esophageal sphincter, allowing us to divide the esophagus into three segments with a transitional zone between the skeletal and smooth muscle portions of the esophagus. We pull the catheter up a little bit, and here we can concentrate in the pharynx. Velopharynx or nasopharynx up here, and then the upper esophageal sphincter moves to the bottom of our display. And with this, we can then concentrate on the pharynx and upper esophageal sphincter and proximal esophagus as our area of interest, using the same catheter, the same software. Impedance was added a few years later. Impedance is, just like we learned in physics many years ago, as a measure of electrical resistance to flow. If the esophagus or a tubus collapse, impedance is high. If it opens, impedance drops. So when you test impedance, you usually swallow a salty solution. And so as the bolus, as the esophagus opens, the impedance drops, it becomes lower. And then behind the bolus, the esophagus and pharynx would contract, and impedance would then elevate. This helps a great deal with not just measurement of, say, reflux, but critical for actually watching bolus flow through the pharynx and the esophagus. Here's a very normal esophageal HRM with impedance study. The purple on your screen being actual bolus flow through the entire length of the esophagus, through an open, relaxed lower esophageal sphincter and into the stomach, while impedance also has a good role in the pharynx and as well, which we'll see shortly. This allowed our gastroenterologist colleagues to classify motility disorders. There have been 3 different Chicago classifications. We're now in the Chicago 3, and that's allowed us to categorize motility disorders in the esophagus and perhaps someday in the pharynx into certain subsets, which we don't really have time to go through here, but are right here before you. Can also be used to look at bolus transit in the pharynx, and here you have a patient who, once again, normal on your left and on the right, the loss of bolus transit in a person with cervical dysphagia. So that's a really quick overview, and at this point I'd like to invite Dr. Ashley O'Rourke to take over the presentation.
Okay, thank you, Greg. I really appreciate the introduction, and good evening, and maybe good morning to some people if you're on the other side of the world. Kate and I are so honored to have you all with us today and spend your valuable time. I do have to tell you that I'm getting over a cold, so if I pause or mute to have a little coughing fit, we'll take some questions from everyone. So I apologize in advance for that. Kate and I are very excited to share our experience here, and what we're going to talk about is incorporation of high-resolution pharyngeal manometry into a clinical practice. And this is into Kate and I's clinical practice, and now this is expanded into my entire clinical practice with my speech pathologists and colleagues. But this is how we have done this. So this isn't necessarily the right or wrong answers. This is how we've explored this modality, and we're welcome to suggestions and also looking forward to expanding this in the future. So we're going to speak now about the diagnostic applications of high-resolution manometry. We're going to look at 4 different areas. We're going to look at characterizing the pharyngoesophageal segment and how that function really interplays with pharyngeal contractility and how that can be seen very well on pharyngeal manometry. Also going to spend a little bit of time on timing, coordination, and the concept of a pressure chamber formation. We're going to discuss how we can use high-resolution manometry as an adjuvant to video fluoroscopy, particularly in the evaluation of some subtle contractility deficits. And lastly, but not least, but unfortunately just with our time constraints, we're just going to talk a little bit about the importance of understanding esophageal function, which I think is essential, and in no means, because we're spending a little less time talking about it, means it's any less important. So if we start with cricopharyngeal function, it really is the most well-studied on high-resolution manometry. So if we take this woman here, and this is her esophagram, and we can see here she has a cricopharyngeal bar and an anterior cervical web. You can see here a little penetration. This is from an esophagram. And if we look at what her high-resolution manometry would look like, it would look like this. This is actually this woman. So what we see here are these really high pressures that she's generating in pharyngeal contractility to push through a closed UES. So there's an obstructive nature here to her upper esophageal sphincter, or the PES, or the pharyngoesophageal segment. So she's really working hard to get things through. So if this is her before, when she underwent a CP myotomy, this is her afterwards. And what we can see here is a nice opening. Remember those cool colors, as Greg briefly spoke about, that those cool colors represent lower pressures. Here we see this nice opening of the upper esophageal sphincter. She's really relaxed those pressures that she needs to generate in the pharynx to drive the bolus through the upper esophageal sphincter. And so one person would ask, well, if you have the esophagram and afterwards she told you that she got a lot better, why do we need high-resolution manometry in the first place? Well, the problem is that Molly Carnegie and her colleague did a systematic review that was published just this year in January, looking at how good are we at showing that our interventions specific to cricopharyngeal myotomy are actually improving swallowing function. And what they found is that they really had insufficient evidence to guide our clinical practice. And one of the outcomes that was suggested by this is that maybe we use high-resolution manometry because it can give us those objective measures as an outcome measure. Because in this changing dynamic that we have in healthcare, we're really going to have to show that we have objective outcomes for our patient, that we're making a difference in more than just a subjective manner. And high-resolution manometry could be a really nice way to do this. Another example would be, this is the woman I showed you before. Obviously, this is an obstructive bar for her, and she got better. But what about this person here? So they also have what somebody may call a cricopharyngeal bar. But what is these are osteophytes here. What is the contribution of these osteophytes to this cricopharyngeal bar? Is this obstructive or not obstructive? What about this? There certainly is an indentation of the posterior wall. That's sometimes what our radiologists like to call it, but this may be a small cricopharyngeal bar or hypertrophy. Or what about this? Many of you may have been taught, like I have, about this little rule of thumb that if it's over 50% of the lumen, then maybe that might be considered obstructive. But what if I was to tell you that this is actually a successful Zinker's diverticulectomy endoscopically completed with a stapler, and that this person is completely asymptomatic, and that this relaxes completely with the swallow because the muscle is actually gone. This is just a little pliable shelf. But high-resolution manometry could help us differentiate between all of these people. So if we have, if we can do targeted interventions, this can lead us to having better outcomes. But these targeted interventions require the appropriate diagnostics, so we have to know what we're treating. So take this person, for example, on the right side of the screen. Here again, you see these high pressures and this high intrabolus pressure in what should be a low pressure zone. opening of the upper esophageal sphincter. But if you look a little bit more closely, what you'll see is there's actually in this mesopharyngeal region. Kate and I used to call this the tongue-based region, but more appropriately, others in the literature, etc. And we have adopted the practice of calling this the mesopharyngeal region because it represents really mostly the middle pharyngeal constrictors, probably some of the superior and inferior, but also the tongue-based retraction. And if you look here, this is a little weaker than we would actually expect. In this area, we would expect to see some of those higher colors like the yellows maybe coming into here, and maybe even some of the red denoting higher pressures in that mesopharyngeal region. This was a gentleman that Kate and I actually treated without any surgical intervention. And what we did was 6 weeks of biofeedback therapy aimed a couple of different things, but one of the main things was to increase pharyngeal contractility. And here you can see him 6 weeks post-therapy, how we do have some increased pharyngeal contractility and opening of that UES, a much more normal, I don't want to say appearing swallow, but also on other measures, he had a much more normalization of his swallow and was eating a regular diet and thin liquids. And Kate will talk to you in a few minutes about biofeedback. But this is just to kind of bring into play that just because we see obstruction here, we also need to see what's going on in the pharynx, and high resolution pharyngeal manometry is one of the ways that we can do that and objectively measure it, as well as objectively measure our gains that we made with that patient, both at the PES as well as in the pharynx. So let's go on to talk a little bit about timing, coordination, and the concept of a pharyngeal chamber formation. There are a lot of really smart investigators out there that are right now starting to speak more, and will be publishing more on this concept of looking at bolus propulsion in a fluid dynamics type of a way. And it makes a lot of sense. And one thing that Kate and I, a year or so ago, were looking at some of our data, and then we started to look at the examples in the literature, and we started to see this increase in the UES, an increase in contractility, these pressures, just before relaxation. And we would see it here in Jones et al. We see it here in Meyer, Dr. Omari and his work, and Dr. Koch as well. These papers weren't specifically addressing this. We just happened to notice it was part of in their data when they were publishing about other things. And so we started to ask, well, why would the UES show increased pressure just before relaxing? And we actually gave this as an oral presentation at DRS this year. And what we did was we looked at the pharynx with Dr. Pearson and his group at Medical College of Georgia, as we looked at the pharynx as creating a pressure chamber. So if you have an opening at the velopharynx, an opening at the oropharynx, you can have an opening at the glottis, as well as an opening of the UES. As the person starts to swallow, they prepare the bolus and they get ready to swallow. That velopharynx is the first closure point. But to maintain and provide a pressure gradient, the UES needs to increase in its contractility so that it can then release and create a low pressure zone this way. This is very preliminary work, but it kind of points to that idea that fluid mechanics may play a very large role in addition to just our pharyngeal contractility and muscle propulsion. We see here in this individual an example of this. So this person has velopharyngeal insufficiency. So if you watch their swallow, they actually have fairly good tongue-based retraction, fairly good pharyngeal stripping wave. Hyolaryngeal mechanics are fair. And I also have fairly good elevation of the arytenoids to the petiole. But one thing that you'll notice is that the patient just is not able to adequately propel the bolus. And one of the major issues is this velopharyngeal insufficiency. So as surgeons, could we start looking more at areas where patients may have these kinds of deficits and be focusing more on surgical interventions to recreate more of a pressure chamber situation? This goes not only with velopharyngeal issues, but also issues such as the glottis, which we already address from an airway standpoint, but also looking at it more as from a fluid mechanics bolus propulsion avenue as well. Also for, as a surgeon, one of the things that I need to know about is my post-operative patients and how they're doing. One of my partners who does a lot of sleep apnea surgery, we were seeing quite a few patients that afterwards had kind of what we would call unexplained dysphagia. We actually published on this last year that there's a very high incidence in post-operative sleep apnea surgery with patients complaining of globus or some type of an irritation or pain, or actually dysphagia. And this was a gentleman who had seen many other practitioners before he came to see me, and he basically had an unexplained dysphagia after his UPPP. And so we'll see him here with thin liquids, and we'll see him with puree. And if you look, there are some subtle things that are occurring here on the video fluoroscopy. One thing that you may notice is overall his swallow is fairly good. So at the outside hospital, this was deemed more of that there was unexplained why he would have this dysphagia. He was currently on a normal diet. But what we did was we did high resolution manometry. And what we found were these subtle differences in that almost the simultaneous contraction that he had here, as well as decrease in those mesopharyngeal contractility. So although as in video fluoroscopy, he was more kind of within the normal limits, or we may say his tongue base may be a little bit weak, here in high resolution manometry, it gave us actually a therapeutic target or even an explanation for why he may be feeling a difference with his swallowing, even if we weren't seeing a functional deficit on video fluoroscopy. Lastly, I kind of want to talk about why is our understanding of esophageal dysphagia important. It is, it's one of the things that we like to compartmentalize. Sometimes we say, well, the speech pathologist and otolaryngologist do oropharyngeal dysphagia, and the gastroenterologists are interested in esophageal dysphagia. But the long and short of it is that swallowing involves bolus transfer from the lips to the stomach. And so the swallowing mechanism is interrelated in both timing as well as function. Dysfunction in one area can certainly affect another. And so we need to understand, evaluate, and be able to treat the swallowing mechanism as a whole. The problem that we have is that most patients just don't come in, unfortunately, and say, this is where my problem is. Because when they do, they're wrong the vast majority of the time. They're very highly inaccurate. In addition to that, it's not just one site. A number of investigators have looked at series of patients where Jones et al. Looked at 40 patients who had these suprasternal complaints, but only less than a third of them had esophageal pathology only. It was 35 of them, 35% had a combined oropharyngeal and esophageal. So that leaves only another third that were really oropharyngeal when they had the suprasternal complaints. Achalasia patients, about 50%, had pharyngeal abnormalities as well. And then a newer study that actually is from MUSC, Dr. Galung, showed that 82% of patients with delayed initiation of pharyngeal swallow also had impaired relationship, but it's an association. And it means that we just need to be prepared to look a little bit further for our patients before we brand them with something. This is just a example of this. I had a nice gentleman who came to my office and he said, food stacks up in my throat. And he was really frustrated because this was the feeling that he had, effort and swallow, and it was localized to his throat, but they were a little bit of vague complaints and it was progressive over many years. He would have minor coughing during and after meals, and he did have some reflux that had been worsening in the last couple of years. He did a modified barium swallow and out through at an outside hospital, which did not have a follow-through, and it showed flash penetration. So my interpretation of that was that it was not significant. We did not have the video available, unfortunately, just the report. He had an EGD, which had normal mucosa and no hiatal hernia. So the question is now what to do next. Do we repeat his modified barium swallow? Do we do a high resolution manometry or an esophagram? And there's an argument for both of these. We, in our institution, we did high resolution esophageal manometry. And what we found was ineffective esophageal motility. And so from before, when Greg was showing you in the introduction, this is that upper esophageal sphincter band, and this is the lower esophageal sphincter band. And here we can kind of see some of the pharyngeal contractility, the opening of the UES, but we don't see that esophageal contractility that we would expect to see. And so this is a failed swallow. And if you have a certain percentage of failed swallows within 10 swallows, then that would be ineffective esophageal motility. And this patient was diagnosed with that and then treated appropriately. And actually his symptoms became somewhat better. Ineffective esophageal motility is something that can be a little bit difficult to treat, but at least it gave us an explanation for what his swallowing symptoms were and gave us some strategies and some compensatory mechanisms to be able to help him.
Hey, Ashley?
Yes.
I have a question from a surgeon in the audience.
Certainly.
If you take your non-Zenker's patients out of the mix, out of 50 patients that come to a tertiary dysphagia center, laryngology center like yours, how many people end up getting high-resolution manometry?
I just want to make sure I understand the question. If we take out the patients that we do this for Zenker's, if we take out the patients, we also do it for cricopharyngeal myotomy. There's actually a pretty significant number because I have a high caseload of oropharyngeal dysphagia. However, I do want to say something. I get requests for people to come to visit, to learn about things. And I think that sometimes people have the concept that we sit around in our clinic and do high resolution manometry all day. And as awful as that would be, that's not really true. We do, maybe a couple of diagnostic, maybe 2 to 3 diagnostic a week on a good week, and maybe do 1 or 2 biofeedback therapy sessions in a good week. And then there may be weeks where we do 1 or possibly none. There might be where we do more. So I don't want to give the impression that we're using high resolution manometry in every single patient. And I don't think there's an indication for it in every patient. We use it when we need something as an adjuvant to help us to make a better diagnostic plan or a diagnostic evaluation and also a better therapeutic plan.
A follow-up question just popped up here is then if you had a contrast study and a good history that led you to doing an endoscopic or an open cricopharyngeal myotomy, would you get an HRM study on that patient beforehand or go right to surgery?
Yes and no. In the setting of if I had a good study and I felt good about what the diagnosis was and I was not concerned that this was something compensatory for uncontrolled reflux or ineffective esophageal motility, then I might go just to cricopharyngeal myotomy or some type of cricopharyngeal intervention. If it was a patient that I wanted to know more about their esophageal function, then it would be somebody that I might get an esophageal study on. I don't have a one-size-fits-all. It's not like everybody that comes in gets a manometry if they're going to have XYZ. It's patient by patient. I have to say I probably do lean a little bit more towards wanting to know what the esophageal function is, although the vast majority of esophageal function studies that we do are geared towards looking at people who are surgical candidates for lower esophageal sphincter augmentation or Nissen fundoplication, etc. I hope that answers that. Okay, Greg, if you don't have any other follow-up, I am going to kick this over to Kate Davidson, and she's going to speak to you about therapeutic applications of HRM.
All right, thank you. So we've done a great job talking about the background of manometry and the diagnostic applications of high-resolution manometry. And I think where we struggle with translation of research in our professions as speech-language pathologists, laryngologists, is really getting at that therapeutic application. We're really good at diagnosing and assessing, and sometimes I think that falls to a wayside, especially good targeted intervention planning. So I hope that what you learn from the back half of this session will be something that you can think about certainly adopting in your clinic. I know acquisition of equipment is certainly one of those hurdles, but consider the use of device-facilitated biofeedback with your patients. So we are, let's see, make sure my mouse takes control. There we go. going to start here. So traditionally, the modalities that we are most familiar with for device-facilitated biofeedback are our fluoroscopy, electromyography or SEMG, and endoscopy. For various reasons, these aren't always the easiest tools to use and don't always provide all the information we need, as with any device. So I'd like to throw manometry in the bunch now and start thinking about that. But with any facilitated biofeedback, we start to adapt this paradigm shift from strength training to skill training. And in order to have successful skill acquisition, there are several things that are required, but I want to talk about three, which is specificity of practice. And that means that incorporating the exercise into the context of functional swallowing. So that's replicating the desired task. And for us, that's simple. That's simply to swallow. And then you have to have a task challenge, which is systematically challenging the system in a controlled therapeutic environment to facilitate that recovery. And aiding those two is the feedback, the biofeedback portion, and providing feedback against that task performance. So it's providing a mechanism for conveying cues regarding accuracy to improve performance of swallowing exercises and strategies. So all of those things combined, we are activating and working on motor activity, but now we're pairing it with more of a motor learning concept as a result of biofeedback facilitating that skill training. And this results in functional cortical reorganization, specifically for the recovery of the swallowing mechanism. I want to give a disclaimer here that device-facilitated biofeedback in any modality, it's just an adjunct tool for the proprioceptive portion of the therapy. It's not a standalone therapy. So you're not passing a catheter on a patient, walking out of the room, coming back 30 minutes later and saying, okay, good job, time to go home. You do need to utilize this with a traditional and a more novel therapy or systematic programmatic therapy. The facilitated biofeedback isn't just about giving cues to the patients either. It's beneficial to the speech pathologist or to the therapist in terms of evaluating the efficacy of your intervention. Is what you've prescribed to this patient working? And in order for it to work, we also have to monitor adherence. And I'll talk a little bit more about adherence and dosing, and in order to track a patient's progress, which is really important for our payers and supporting what we do in the clinic. And then finally, the exciting thing about biofeedback is that it's not just subjective. Oh, I think this patient's doing well. They performed 10 effortfuls today, and that's more than the 9 that they did yesterday. But now we actually have quantitative objective data that we can include in our reports. So how has this been used historically, and where are we going with this? So historically, there's good data out there to support the use of HRM biofeedback for fecal incontinence. Now, that's a different end than what we're interested in, but there have been several studies that show promising data in terms of being able to control sphincters using the HRM biofeedback. Moving up more into where we're a little bit more comfortable, for Gordon and al. Presented a case in 1984, a case of a patient with reflux where they were able to train that patient to tighten the lower esophageal segment using HRM biofeedback. However, this wasn't ever reproduced in a larger cohort, so we just have this one case to go on. And even more recently, Nativ and colleagues presented at DRS, and I believe COSM as well, some findings from a study where they had normal subjects that were able to increase their UES baseline and maximum pressures using HRM biofeedback. And these findings were statistically significant. They also reported that subjects showed a trend towards decreasing the UES or PES pressures, but there was no statistical significance for UES relaxation during swallowing. Now, these were in normal, healthy adults, and you'll see later on that in some of our impaired patients, we have been able to control for PES relaxation during swallowing. And furthermore, it's just technology increases and improves. You saw where Greg demonstrated what an old catheter looks like with maybe 3 or 4 sensors. But now we have these increased number of sensors. This really enhances the use of the tool for biofeedback in the pharynx, given that it's such a small space. So who's a good candidate? Who should you consider as you're looking through your caseload to maybe perhaps use HRM biofeedback as part of your intervention plan? Well, these are going to be patients with adequate cognition. So you don't want to use this, since it is rather slightly invasive, on patients who are combative or aren't going to be able to understand the procedure or the protocol. You also have to have patients who have adequate vision. This is very visual therapy. So we're using those topographic pressure plots for pattern recognition in these patients. So vision is key. You have to be able to pass the catheter without visualization, and I will say that is in the context of perhaps a therapy room if you don't have endoscopy present to be able to pass the scope. And to pass the scope to help facilitate catheter placement. So, for example, a patient with severe kyphosis, if you aren't able to pass blindly without visual aid in the context of your therapy setting, this perhaps is not the patient to be performing this procedure on, given the close proximity of the airway. And then you also want your patients to be able to tolerate the catheter for extended periods of time. We're going to talk briefly about some pilot data for our protocol that we use at MUSC, but our patients generally will tolerate the catheter to 15 to 30 minutes. If you have a patient who is very hypersensitive, perhaps this isn't the patient that you would want to be using HRM biofeedback for. And then finally, and most important, is that these patients have to have some sort of observable phenomenon happening in the pharynx. So pharyngeal contractility or intrabolus pressures reading. So I show you here this example of this patient. You're going to see a few swallows coming up here. Here's a swallow. Here's a swallow. And so what we're seeing is that there's relatively minimal pharyngeal contractility. You have a little bit of the velopharynx signaling there, and even minimal UES opening. So for a patient to use this for biofeedback, there's not really getting any proprioception from this signal. So thinking about perhaps not using this with these patients and or waiting until they have developed some level of strength to be able to show a signal. So let me jump back. I want to talk about the different applications that you can use in therapy, because it's not a one-stop shop or one fits all type deal. So just like we target or individualize our therapy for swallowing based on swallowing physiology and what we're seeing on modified barium swallow study or with our HRM diagnoses, we have different applications that we can use, and you see them listed here, and I'm going to go through each one, keeping in mind that each plan is individualized for the patient. So something that I found very useful in therapy is maneuver and strategy planning. We have very limited time in the video floor room or even doing endoscopy or fees. We have the whiteout during the swallow, so we can get good cues before and after the swallow. But I found that a really great way to plan strategies and maneuvers with patients is using manometry during their therapy sessions. I'm just going to show you this very quickly. I'm going to talk you through what you're seeing. This is a patient's baseline swallow. So what we're seeing is decreased pressures in the mesopharyngeal region and no UES opening during the swallow. So we're going to try an effortful swallow now to try to increase those pharyngeal pressures and drive. We do see some increase and we do get better UES opening. Now let's try a head turn. Much better UES opening here and even more contractility occurring in that mesopharyngeal region, but let's combine them and see what happens. And what you see is really nice contractility through the mesopharynx and that nice UES opening. So that's just a very quick way to pass a catheter on a patient and try a couple of different procedures without fluoro to be able to see what is going to really maximize the patient's contractility for swallowing and that pressure drive. Training exercises and monitoring those exercises. This is probably one of my favorite ways to use the biofeedback with our patients. And I recall very fondly this patient here who, if you look, what we're seeing is a Mendelssohn maneuver. And what we expect to see is these prolonged velopharyngeal contractions, increased tongue-based contraction, prolonged there, that rise in laryngeal elevation and the fall, the nice UES opening. And you see in session 1, this patient's first attempt. Historically, I'll give you a quick background. This patient came to us from an outside facility where he had been participating in therapy for, I believe, 2 to 3 months. Everyday therapy, in-home, in-health training, coming and doing Mendelssohn's with him. And from an external view, he did. He was very aggressive and excited about his Mendelssohn's, and he looked like he was achieving the adequate dose for adherence. But when we pass the catheter, what we see is he really just wasn't doing much of anything in the pharynx itself. So you can see the progression with this pattern recognition and the exercise training from session 1 all the way to session 6. And we'll talk about dosing and adherence in a minute, but this patient is really maximizing his therapy now because we're able to see that if he is adequately performing his exercise. And just over here to the right, you see how his pharyngeal contractile pressures improved over time, his UES opening duration increased over time, and his relaxation pressures decreased. And these are all things that we want to see. Another application for manometry in biofeedback is looking at temporal coordination. So we're not just looking at strength, and we're not just looking at the strength of the pressures. We also want to look at the timing of those pressures. So if you look at this patient, session 1, over here on the left, you see these really hot, warm colors, and high pressures aren't always great for swallowing. So this patient is essentially simultaneously contracting. And I'm going to play as modified a single swallow here really quickly, but what I want you to pay attention to is the posterior pharyngeal wall. And you'll see that it essentially just contracts all simultaneously, and this is going to result in aspiration. I know that goes really fast and it's rather small, so take my word for it, but that's what's happening here, is this sort of simultaneous contraction along the back. Now let's compare this to session 5 with this patient, where essentially we did something called coordinate mapping or pattern recognition with these patients, where they're watching the screen and they're watching their manometry, and he's looking and matching and pairing towards an ideal goal target image that we're putting up on the screen next to it. So he's got these much more normal colors. He's not aggressively contracting, and he does have more of a temporal sequential contraction through the velopharynx to the hypopharynx. And you'll see, again, focus on the posterior pharyngeal wall here, much better sort of superior to inferior contractility, which we would expect to see with this patient. Interestingly, again, we talked about in the TIF study in normals where there was a trend towards patients being able to relax the PES but not reaching statistical significance. It'd be interesting to do this study in patients with dysphagia impaired patients, because you see this example here. This is a single session, trials 1 through trial 20. The patient's only cue is to match the target swallow. And again, like I said, they will have a target swallow that's posted up on the screen or next to the computer. So they're looking at what the ideal normal swallow will look like. And my only cue to him was match that swallow. I want to see more blue in the region of the UES. And so over 20 trials, the patient manipulated his swallow without any cue from me, just the cue from the signal or from the screen, to be able to achieve increased UES opening. And what you see he's really doing is using that pharyngeal drive to help facilitate opening here. But I didn't have to explain that to him. He was able to do this on his own. And this is just an example of a biofeedback therapy session with swallow mapping. Hopefully the audio will play for you. But if not, I'll describe what's happening, and he's closed captioned as well. So I'm just telling him to swallow. You're going to see the swallow come across the screen. This is this patient's last session, so he's very familiar with the procedure. And so I'm asking him how he felt about that swallow. And so he's saying he pushed his tongue to the top of his mouth and then he pushed it back, and that's what he did to achieve that color. It's a common thing I've had to focus on because it doesn't seem natural to intentionally do that. So you just see a good example here of how this works in therapy. The patient is swallowing, he's getting that kinesthetic proprioceptive biofeedback, and then he's describing what he's feeling and what he's doing to help manipulate and change what he's seeing on the screen to meet our visual targets that patients will all learn and be oriented to on their first session. And again, you see he's not in any pain. The catheter is placed, it's taped to his nose. It's relatively comfortable and easygoing. So here's the, I think really the gold ticket question these days is, how much should I be doing with my patients? What are the repetitions? What should I be doing in terms of intensity and duration? How much is too much or how much is not enough? So when we think about dosing adherence, and I have to give a shout out to Brittany Kreckler, who I just had some time to discuss this sort of concept with. And so she was very generous in providing her knowledge with me, but it got me thinking about how we use this for manometry. And so when we think about dosing and adherence, we really have the PT and OT literature to rely on, but we know that limb versus cranial nerves act very differently. So we can only really surmise from that literature what's best for our patients. So dosing, again, it's the intensity, it's the repetition, it's the frequency, it's the duration of the targeted intervention of the therapy. The dose itself is the assumption that the exercise is done correctly. So it's what's delivered. So that would be your goal. The patient is to do a Mendelssohn with 100% accuracy 10 times in a row. So 10 times is your dose. However, in reality, adherence is what's actually being achieved. So I want you to take a look at this patient, for example. This is trial 1 through trial 10 in a single session. This again is a Mendelssohn, so we're familiar with that now. Trial 1, this Mendelssohn looks really good. The patient's achieving the adequate dose. He is adhering to the exercise. And this progresses on through trial 6. Somewhere between trial 6 and trial 10, though, the patient's no longer doing a Mendelssohn. He's really just contracting his velopharynx and way after the swallows. This is not an actual Mendelssohn, even though the patient probably feels like it is. So somewhere in between trial 6 and trial 10, we stopped achieving the dose because the adherence was not met. So our dose wasn't 100%, it was probably more like 80%. What this does is it facilitates a mean of maximizing our dose and setting realistic goals for our patients. So I would say to this patient, based on when his last successful trial was, your repetitions are now going to be 10 in a row until I can see that you're getting the accurate dose for what, or the accurate adherence for what I have dosed you. So this is an exciting thing for me in terms of being able to provide my patients with realistic goals in a clinical setting. And finally, just to wrap up, we're working on publishing this and writing it up, so hopefully this will be out there soon for you. We'll have the protocol and the full data set available as soon as we can get that published. Sorry, my screen is jumping. But what we did is we took 10 patients, and they participated in our biofeedback pilot program. They attended 1 weekly direct therapy session using HRM-facilitated biofeedback for 3 to 6 weeks. We monitored their improvement, and subjects were discontinued in therapy once their individual goals were met and/or it was felt that they had plateaued in therapy. To summarize quickly, 7 of our 10 patients showed improvement in our HRM parameters. And of those parameters, we saw an average increase of 87.1 millimeters of mercury for our pharyngeal contractile integral, 37 in velopharyngeal contract integral, 45 the tongue base or the mesopharyngeal contract integral, and then 7.5 in the hypopharynx. Their EAT-10 scores improved, their DHI scores improved, so their quality of life was improving, and there were no adverse events. And we did look at other variables, but these are what we're reporting here. I'm gonna try one more time to see if I can get this audio to play, because this is such a great testament from this patient.
Okay, I really want to try working on getting my swallow back.
I almost didn't.
Yeah.
I almost said I was just stay on my feeding tube, but I think it was because I wanted to taste food again, and the feeding tube, I wanted more, basically. Yeah. So I just told myself that I need to try to start.
Okay. And what did you start out with therapy?
With therapy? Started with the microphone, I believe, on the throat.
The EMG?
EMG on the throat.
Okay.
And I was swallowing like I was trying to swallow, but I really, it wasn't comprehensive to me, and I couldn't really mechanically see what I was having to do to improve on that.
Okay.
So I was kind of at a standstill, if you want to call it that.
So you did the EMG for a few sessions, and then you tried the high resolution manometry. So
Right.
tell me a little bit about that.
That was the changing point in me because I'm so mechanical. And I started to see my pressures instantaneously.
Okay.
Really. And and I was seeing what muscles to me I had to move. And whether I was holding the neck back or turned to the side or what the best procedure was to help me start swallowing again.
So I think the video speaks for itself, but this is a patient who tongue-based cancer resection radiation, and he was very successful with high-resolution pharyngeal manometry, where he failed with submental EMG. He is an engineer, so the way he describes that is from an engineer brain, which is why I think that his testimony is so exciting for us. So very quickly to wrap up, so we have time for questions. In summary, just a few take-home points. We can use manometry as an adjuvant diagnostic tool. It's helpful to identify our therapeutic targets for setting individualized targeted treatment plans that we can prove to be with efficacy. And it's particularly useful in characterizing PES segment function, where video fluoroscopy or endoscopy may not be able to provide that sort of information. And then, of course, even though we didn't speak too much to it tonight for time constraints, but understanding of esophageal function in the evaluation of oral pharyngeal dysphagia is important. It is a continuum. So I'm going to pass this back over to Dr. O'Rourke for future directions for manometry.
I think we're going to take a few questions.
I have a question for the two of you right now. And what exactly is the role of the two of you together, or your team, Ashley? Do you do the HRM? Do the speech therapists do it independently? And if you could, we don't have much time left, but very briefly touch on the billing concerns as well.
Sure. So we do both pharyngeal, pharyngoesophageal, as well as esophageal studies. So it just depends on the patient's complaints or why we are ordering the study as to which one we do. Many times I have to say we do a combination of a pharyngoesophageal, so we'll do the pharynx, we'll do 10 swallows of the pharynx, drop down, do 10 swallows in the supine position or semi-recumbent position for the esophagus. And so I have a speech pathologist in clinic who works with me, who does all of our manometry that are diagnostic. And then we also have speech pathologist Julie Blair. We also have another speech pathologist just recently joined us, Angelina Schnapp, which we are very happy to have her too. And they both do diagnostic pharyngeal and biofeedback therapy for the pharynx. So it's a combination of us, but mainly the speech pathologists have taken over. Now I do analyze the studies, particularly the esophageal.
And in terms of billing, that's a big question that we get a lot. It really depends on, one, your setup and how you're structured. Is the SLP under the laryngologist, or are they functioning sort of as a maybe a contracted service? For us, we are a separate department, the speech pathologist, and so we do bill just a therapy code. There is a biofeedback code that you can bill on top of that. I don't have those codes in front of me, but I'm happy. We'll provide our emails and we can send you that information. Ashley, do you want to speak to how you bill for your evaluation?
When we do a pharyngoesophageal manometry, we bill that as an impedance pH study.
Another very insightful question came up and was the outcome of the improved pressures after therapy verified on video swallow studies? Because we know that more pressure does not always equal more effective or coordinated swallowing?
Yeah, really good question. And so I wish I had all the time in the world to share the entire study with you. But yes, we do have pre and post modifieds, and we do have the physiologic changes that occurred, and we can describe that. Primarily, if I recall, actually I have the little poster right here. Our primary improvement was in laryngeal vestibular closure, interestingly, pharyngeal residue. Our PAS scale scores improved, tongue-based retraction, pharyngeal stripping wave. And interestingly, bolus transport lingual motion improved. And I don't know if it was because patients were thinking more about the swallow and planning as well. But we do have that data. We do have that simultaneous data for some of these subjects. And we will certainly try to publish that as soon as possible.
A question came up as well here about HRM and Zenker's patients. There are manometry studies that have been done in the past on pre and post-operative Zenker studies. We started one at Wake Forest, and it was so difficult to insert catheters in our patients with cervical diverticulums that we stopped. Are you trying to do that, Ashley, since you have a fluoroscopy suite right there in your office?
We don't. I mean, we don't do a lot of manometry studies on Zenker's because the Zenker's is usually symptomatic. There's regurgitation, there's penetration or aspiration after the swallow, and it's something that you kind of have to deal with. But we are not routinely using them for Zenker's population. I am for cricopharyngeal dysfunction, more so, not for everybody, but more so, but it's not routine for us to do it for our Zenker's patients. I don't know what else I gained from that. I'm sure there was actually a presentation recently, I think at COSM, about that, but so there is some utility that some have shown, but in my practice, I don't routinely do that. I feel like it's a pretty straightforward surgical.
Can you differentiate ineffective motility from decreased contact of pharyngeal structures without simultaneous contrast study? It's a tough question.
To think about it.
Right. I think with the circumferential pharynx, no, I don't. I think if you had someone like, okay, that neurosarcoidosis patient that Kate showed you, where you had where she said that person wouldn't be appropriate for biofeedback because you didn't have a lot of pressure generation on the pharyngeal catheter. In that patient, you could say, well, maybe she did have some preserved. That lady was actually eating some. I mean, it wasn't, she had a PEG, but she was actually taking some PO. We were using, for her, actually biofeedback with fees. So she obviously had some contractility. It was just, we did not measure any of that on the pharynx. So there is a very broad range, just like the esophagus, of pharyngeal contractility. Of what would be considered normal in the pharynx. So certainly you could think if you're at the lower end, but it would be hard for me to think, and of course this has not been studied, so this is my opinion. It'd be hard for me to think that you have a single area like in the mesopharynx that isn't making contact, but you're making great hypopharyngeal, you're making great velopharyngeal, and if you have complete dropout in that mesopharynx, that somehow that was a contact related with a circumferential catheter. Maybe somebody could show that, but I don't think that would be the case. Could it be that maybe you're sidelined on one side and you're getting lower pressures than the patient actually has? Yes, but that may be within the realm of the range that we have of normalcy.
And I do want to just throw in really quickly that, again, thinking of manometry as an adjuvant tool. So it's not the only tool that we're using. By all means, if we're going to be developing a targeted intervention plan, we need to understand swallowing physiology. So our patients do get both manometry and then, if indicated, or vice versa, the manometry. So we look at the whole picture. We're not just blindly throwing out exercises.
That's an excellent point.
Ashley, do you have a few last slides there to share with us?
Yes, I do. So let's just talk about some future directions just to see where we can go from here. First of all, we need a validation of our measures, and I think that answers that's kind of a redress to that question that somebody had. We need to know what's normative data and also to look at the varied disease states, which a lot of people are starting to do. one of the things that we need to do is start speaking a common language. And a couple of years ago, we developed an international high-resolution pharyngeal manometry working group. And under Dr. Taher Amari's guidance of the subgroup of that, we have come up with a minimum core outcome set that we have submitted for publication. And hopefully that will help to guide us, for those of us who are studying and using this as a research tool, to start speaking a common language together. Also, just to talk about this as a screening tool for dysphagia, that right now we're using it as an adjunct diagnostic. Could this be something that maybe we could screen severity in patients who cannot be transported for other studies, or where fees may not be available, something using more like a swallow risk index? So I encourage, if you're interested in that, to look up some of Dr. Amari's and Dr. Rommel's work on that. We really need to objectively evaluate our outcomes. And some of the questions that we've gotten are excellent, because they're those critical questions of, are we seeing what we think we're seeing? And with a new technology, those questions are critical as well as the answers. And so I really applaud that, because I think we need, not just to go down the golden path. The other thing is that pharyngeal specific software would be very helpful. Kate and I have worked in conjunction with Medtronic for a pharyngeal specific software program, and that's going to go into beta testing soon. That would really help with this component of biofeedback. And just one more plug for my friend, Dr. Amari, is that if you went to the swallowgateway.com, you would actually be able to utilize pharyngeal software and upload your studies. So if you're interested, get in touch with Dr. Amari and look up that website. Lastly, we really need training and education. If this is going to go forward, we need to speak the same language. We need to critically evaluate what we're using, but we also need to provide very good training and education. And I see some of that now with esophageal manometry, where the gastroenterologists are starting to implement some sort of formal training or assessment for esophageal manometry, and looking at competency there. And through the international working group that I lead, we're also, Molly Carnegie is heading up the subgroup on training and education, and ASHA has, the SIG 13 has also gotten involved in this too, and looking at some basic competencies. So that's something that we're becoming interested in, and I think is very useful for the future and where we should be. I want to put in one plug, and then we're done, for the Charleston Pharyngoesophageal Manometry Program. If you're interested in learning more, please contact us. This is going to be an inaugural training program in January. I'll switch it back to you, Greg.
Well, the final comment, we'd like to thank all of our panelists and all those people that stayed with us till 9 o'clock. And I want to give a shout out for the next Fall Voice webinar coming up as soon as you see on your screen. It will be it'll be on lifelong learning and laryngology, moderated by Clark Rosen, with the panelists Rebecca Howell, Milan Amin, David Rosso, Maya Braden, and John Lynn Langenstein. And we hope to see all of you there. Thanks again for your attention and for your joining with us tonight.